When you look at the Swedish trial, 600,000 women, half of them screen with mammogram, half of them don't. The same number of women die of breast cancer in both groups. The only difference is the women who screen with mammogram have 20 to 30% more cancers in that group. So they're being diagnosed with more cancers, but they're not dying of breast cancer any more than the women who aren't screening. When we do autopsy studies, not on women that died of breast cancer, but on women that died of suicide, car accidents, overdoses, do you know that 20% of them will have evidence on pathology, on histology of breast cancer?
No.
20%?
No.
Yes.
We didn't talk about that last time. No.
Yes.
Are you serious?
Yes.
Some of the most powerful conversations on this podcast are the ones that don't end when the cameras stop rolling. After our first episode together, I heard from so many of you, women who finally felt seen, who began questioning old narratives about screening, and who wanted to know what to do next. That's why I'm so grateful to welcome back Dr. Jenn Simmons to the show for part 2 of this powerful and, yes, controversial conversation.
Our bodies are constantly making cancer cells. It's just a reality of what happens when you constantly turn over cells, like Michael Keaton in Carbon Copy.
Right.
You remember that
yes,
movie?
I do. Yeah.
Some of them are going to be number 3.
Right. Okay.
Right?
Yeah.
Like some of them are just not going to work out well. A healthy body with an intact immune system is going to be able to take care of that, to contain it, to reverse it.
For those of us joining us for the first time, Dr. Jenn Simmons is an integrative oncologist, a breast surgeon, an author, and founder of Real Health MD. She was Philadelphia's first fellowship-trained breast surgeon and spent nearly 2 decades leading one of the region's top breast programs. After facing her own health crisis, she transitioned from conventional surgery to pioneer a new integrative approach, one that merges science, functional medicine, and lifestyle medicine to help women truly heal. In this episode, we'll continue the conversation, taking your questions, exploring the latest research, and asking what real breast healthcare looks like today. Please join me in welcoming back Dr. Jenn Simmons. Okay, before we jump in, quick health check. Are you subscribed yet? You'd be surprised how many people forget the one click that actually helps them feel better every week. Go ahead, hit it. Around here, we turn science into self-care you can actually use. Let's get started. Dr. Jenn,
Hi.
I am so happy to have you back. So for
Thank
those of you
you.
who don't know, this is like a part 2 for us. We did an episode, I think, a couple months ago, and that episode went crazy, absolutely crazy. I have some of the questions from that episode that I actually want to ask you. But I think some of what really touched a nerve, we need to revisit, and I want to almost go deeper, if that makes sense. Because we talked about mammograms and we talked about whether they really are the right tool for breast health and for screening and for cancer prevention and all of these different things that we've been kind of brainwashed and led to believe over the years. We talked about, some of the training that we received as, medical students and residents and the disconnect of that training from basic things like inflammation and diet and, the role of lifestyle and emotions and all these different things. When we touched on a lot of that in that first episode. But what happened after the episode was a barrage of questions that I didn't really feel, to be 100% honest, equipped to answer. And that's why I wanted to bring you back, because I wanted my audience and my community to hear from you and for you to also maybe go deeper in some of these statements that we've been making over the last few months as we're really trying to push people forward. So let's start with first just kind of laying a foundation and laying some groundwork. And we're going to do this again, guys, and I don't want you to roll your eyes or change the channel, but this is really important and we're both very passionate about it. But you very clearly stated that you do not think mammograms are the tool that we need to be using to screen ourselves when it comes to breast cancer and breast cancer prevention. Can you go back to that statement for just a second?
Yeah. So it comes down to this. This has become another example of virtue signaling.
Virtue signaling.
Yeah.
Okay, you're going to have to explain that too.
Yeah, absolutely. So We decided in the 1970s that mammogram was the right thing to do, right? It's the morally right thing to do. We should screen for breast cancer, catch it early. And if we catch it early, we will save lives and save breasts.
Mm-hmm.
And it's a lovely theory. And it does make you feel virtuous if, in fact, that's what it does, right? It does make it seem as if you're doing something really
Being
good.
proactive.
Yes.
Right?
Yes.
Yeah.
So you feel good about it. The system feels good about it. Like it all makes perfect sense. Only it's not true. It was something that was sold to us. It was a brilliant, wonderful, heartstring-wrenching campaign. But mammograms don't save lives and they don't save breasts. And we have known this since the late 1970s.
So when did mammograms enter the scene? What were we doing before?
Before, we weren't really screening for breast cancer.
So we weren't doing anything.
Mm-mm.
Okay, so this seemed like a level up, maybe.
Maybe there were physical examinations.
Right.
But mammograms entered the scene in the late 1960s. And there is an English physician named Dr. Michael Baum.
Mm-hmm.
He's a surgeon. And he actually was the founder of the mammographic screening program. And it was based on a study in the late 1960s, the early 1970s, where it was an invitation to screen study. And so already that has some bias because who are you inviting to screen? Probably the more healthy people. And when you do a study based on invitation to screen, the study participants are those that show up. So it's not...
It's like the surveys, right?
Yes.
So
right.
Only certain people are going to show up when you do a survey.
Yes.
Yeah.
So when you compare the people invited to screen and those that show up to the general population, already there's a significant bias there. So already it's going to look like mammogram does something that it doesn't do. But beyond that, what happened with that study is that they found that when you look at 1,000 women over 10 years, if you screen with mammogram, 4 out of that 1,000 will die of breast cancer. If you don't screen with mammogram, 5 out of that 1,000 will die of breast cancer.
Okay, so that's the part that everyone started to really, get muffled with, so to speak. I can't think of a better word. So 4 die without screening and 5, excuse me.
4 with screening.
Okay.
5 without.
Okay, so that's
so
very...
5 is 20% more than 4. And so the headline was mammogram reduces the risk of dying of breast cancer by 20%. And that is what we built our entire worldwide mammographic screening programs on.
So
that study.
They didn't recognize this in the beginning?
They did.
And so why did we sort of
because
die on that sword?
Because everyone responded to the headline, didn't look any further into the study, and it was really good for everyone because suddenly when you start to screen the population, what you really do is diagnose a bunch of, I want to say, quote unquote, good cancers, cancers that would have never affected anyone in their lifetime, would have never become clinically relevant, but because we can see them microscopically, give them a diagnosis, treat them, and then call them cured, it's like throwing someone in front of a train, pulling them back and saying, I saved your life.
Okay, so you said so much right there. So good cancer, come on, is there any such thing as good cancer?
Well, the thing is, when we look at autopsy studies, and I do want to get back to that original study and Dr. Michael Baum.
And we will.
Because it is his biggest regret in his life that he started the mammographic screening program. And he says that. But when we do autopsy studies, not on women that died of breast cancer, but on women that died of suicide, car accidents, overdoses, and we do serial sections through the breast, do you know that 20% of them will have evidence like on pathology, on histology of breast cancer?
No.
20%?
No.
Yes.
We didn't talk about that last time. No.
Yes.
Are you serious?
Yes.
What kind of breast cancer?
I mean, a lot of it's going to be DCIS or ductal carcinoma in situ, but it's not exclusively DCIS. And what we have to realize is that our bodies are constantly making cancer cells. It's just a reality of what happens when you constantly turn over cells. Like some of them are going to be like Michael Keaton in Carbon Copy.
Right.
You remember that
yes,
movie? Like
I do. Yeah.
some of them are going to be number 3.
Right. Okay.
Right?
Yeah.
Like some of them are just not going to work out well. But a healthy body with an intact immune system is going to be able to take care of that, to contain it, to reverse it. And you don't need the medical system involved in doing that. Our bodies are very intelligent. They can take care of it. So not everything that on a microscopic level is actually going to develop into disease. But if you use a really unsophisticated tool like a mammogram,
right,
then you are going to find these things in their infancy, and you have no way of determining, because there's no kind of functional aspect of that test. It's either, yes, this is normal, no, this is abnormal, and they go on to all the rest of the stuff. So we are picking up these cancers or these changes in their infancy, and we're giving them a diagnosis, even though the natural history of it is that it would not have progressed. And we know this from very, very large scale studies. So when you look at the Swedish trials, 600,000 women, half of them screen with mammogram, half of them don't. The same number of women die of breast cancer in both groups. But the only difference is the women who screen with mammogram have 20 to 30% more cancers in that group. So they're being diagnosed with more cancers, but they're not dying of breast cancer any more than the women who aren't screening.
And this goes back to when we look at stats and we say, okay, we're diagnosing more breast cancer, but the actual mortality rate hasn't shifted. Correct? It hasn't really changed.
The absolute number hasn't changed. So they're saying the mortality rate is improved, but if you diagnose a bunch of people who would not have died of the disease with the disease, and then you measure mortality rate, of course it's going to look favorably in that group. But when you look at the absolute number of women who die of breast cancer every year, that hasn't changed. So why, if mammogram saves lives, why hasn't that been impacted? Why haven't we decreased the number of women dying of breast cancer every year?
So let's go back. You mentioned, and I'm blanking on his name.
Dr. Michael Baum.
Yeah, let's go back to that. So you're saying his work was actually the biggest regret of his life. Tell us a little bit more about that.
Well, so when we go back to that original study, the 4 women dying of breast cancer versus 5 women dying of breast cancer, when you look at the number of women that die of cancer in both groups, they're the same. And then you look at the downstream effects of screening with mammogram, because if you screen with mammogram, yes, you'll save 1 less woman in 1,000 of dying of breast cancer, even though in both of the groups, 11 women died of cancer. But you will also cause 100 women to be called back for additional views, biopsies,
all the
overdiagnosis, overtreatment. That doesn't happen in the group that you don't screen with mammogram, right? So the actual cost is far greater on the side of screening with mammogram, because we're not really saving lives. The overall survival doesn't change. we're not really saving lives. We are creating the illusion that we are. And that illusion is twofold. First of all, just based on the design of that original study. But the other thing is that when we do these studies, we create these surrogate endpoints. So we're not really talking about overall survival. We're not talking about, do these women live the same or longer than the women that don't get screened. We're saying that we're calling survival 5 years or 10 years or something like that. So it is marred by something called lead time bias.
Okay.
So let's take two women. They're both going to die of breast cancer at the age of 60. One woman is not screening, and she gets diagnosed at 55 and dies at 60.
Mm-hmm.
Statistically speaking, that woman died of breast cancer. Another woman who's using mammogram, she gets diagnosed at 45. She still dies at 60 of breast cancer, but statistically speaking, she did not die of breast cancer because she survived 5 years. She survived 10 years. She's a survivor.
Oh my gosh, the way we define these things.
Yes. So when you assign these surrogate endpoints, 5-year survival, 10-year survival, then you're losing the forest through the trees.
So being a survivor, when we see the walks and people wearing T-shirts and all the things that we see out there and they say I'm a breast cancer survivor, that's defined as a 5-year or 10-year survival rate. Mm-hmm. Wow. I didn't even know that, to be 100% honest.
Yeah.
Okay, if Dr. Michael Baum was sitting here today, what would he say to me?
He would say, I'm sorry that I ever started that program, that I ever endorsed that program, that not only are we not saving lives, but we have created this whole system that only benefits the system, that there is no benefit to the women. And we go back to, we know that mammogram doesn't save lives, but if it saved breasts, that would be a worthy endeavor. It would be.
Right.
It absolutely would be. But the only thing that mammogram has done is has increased the mastectomy rate. So it leads to a 20% increase in mastectomy rate for several reasons. Fear, finding little things in other areas of the breast and kind of saying, well, let's just throw the baby out with the bathwater.
Right.
And so it's really unfortunate. And at this point, it's such a monster with so much momentum behind it.
And money.
Right? That's part of the momentum.
Right.
And people have been so conditioned to believe that mammograms save lives that it's nearly impossible to unring this bell. And it has become virtue signaling.
So let's dive into some of the headlines around this as we try to pull this apart here. So recently, I believe, and I may have this wrong, but Switzerland banned mammograms. Is that true?
Yeah, that's fake news, unfortunately.
That's fake news. Okay, tell us about that, because many people are coming.
They did get a recommendation to do that.
Okay.
And because of the virtue signaling behind mammogram,
right,
and probably one of the world's biggest names and experts in mammographic interpretation, Dr. I think his name is Laszlo Tabar, who is from there or is Swedish. And he was very connected in the government and said, how can you do this? And people want this. And it all became about this kind of moral stance on people want this. That's why we should do it. Right.
But it didn't actually happen.
It did. He had the whole thing turned around and reversed because they were going to get rid, and I think they largely have gotten rid of their kind of mandatory or community screening programs. Now the people that want to screen can screen, but I don't think that they have formal screening programs anymore.
Gotcha.
And the people that screen there, it's nothing like here. So if they screen there, it's once every few years. It's not a yearly thing like it is here.
Interesting.
Yeah.
Okay. And then another.
I wish that were true, but it is
It's
fake
not true.
news.
Okay. Good to know. And then another headline, I don't know if this caught you, Ananda Lewis. Did you follow her case at all? She was, I think in our time, kind of a big MTV VJ, DJ.
Yeah.
And I believe she got diagnosed with breast cancer, chose not to do repetitive screening. I think she chose not to do treatment, and she ended up dying fairly young. She's probably right at 50, if that. So again, I don't know all the details of her story. I don't know if you paid attention to that. But in our comments from our first episode, you know, there's some comments about that, like, oh, remember Ananda Lewis, remember what happened to her, you know, those type of things. So
they love these stories, these cautionary tales.
Right.
But the data just speaks otherwise. So no matter how many mammograms we do every year, the same number of women die of breast cancer. No matter how many mammograms we do every year, the same number of women present with aggressive disease. She had aggressive disease. Would conventional treatment have helped her? Because I know that she opted out of all conventional treatment. I don't know. I honestly don't know. I don't know anything about the specifics of her pathology.
Right.
But young women with aggressive cases of breast cancer, can some of our treatments delay the inevitable? Yeah, probably. And can we get them to fit into that 5-year survival statistic? Maybe, even the 10-year survival statistic? I don't know. But the truth is that most breast cancers, they are what they are from the very beginning. So if it's going to be aggressive, it's going to be aggressive from the very beginning. This is actually why mammographic screening doesn't work. Because breast cancer doesn't follow some linear, predestined progression. It's not like it starts really small as atypia or abnormal cells, and then it becomes non-invasive, and then it becomes invasive, and then it becomes node positive, and then it becomes metastatic. It would be nice if it worked that way, and there are some cancers that you can predict their behavior, like cervical cancer, like colon cancer, but it's not true of breast cancer. Like, there are some people with breast cancer that de novo from the beginning have metastatic disease.
Wow.
There are some people who have DCIS that will either never progress, ductal carcinoma in situ, that will never progress to be invasive cancers. In fact, it's around 80% will never progress. And some of them, it will just regress and go away. And then there's everything in between.
Do we understand what drives what?
Not exactly. I mean, we can look at the behavior of the tumor and some of the prognostics associated with the tumor and guess, but we don't have any test right now that determines what the progression of this specific cancer is going to look like. We have some predictive models, things like the oncotype, which determines who does and doesn't benefit from chemotherapy. We have a predictor of who does and doesn't benefit from radiation. But we don't really have a good test to pair along with a biopsy to say who does and who does not need treatment.
That's so
and
frustrating.
That is where we should focus our time, energy, and money. But that's never happening.
So I want to break some of that conversation down a little bit more because, again, going back to the comments from our previous episode, there were things like, well, you know, if I hadn't shown up, I would have been diagnosed with stage 4. They caught it early. So-and-so didn't go and had stage 4, got mets to the brain and then passed away. You know, when we're thinking about the aggressiveness of cancers, is there a way we can organize it in our brain in a particular way? Like, if you've been given a diagnosis of DCIS, what is your caution level? What do you need to think? If you've been given some of the other diagnoses, right? And we probably should walk through some of the other types of breast cancer. Like, what do you do? Where do you go? What do you start thinking? I've gotten questions, I just had to get on the phone last week with a dear patient, been coming to me for years, probably almost 15 years, recent diagnosis. And I think her diagnosis is stage 1 ductal invasive carcinoma, not DCIS, but ductal invasive
ductal
carcinoma.
Yep.
So that's her diagnosis. Other people have the papillary inflammatory cancer. Some people are ER positive, PR positive, HER2 positive. Some people are triple negative. Can you organize this for maybe everybody listening today to kind of put it into buckets so that we can kind of organize our brains a little bit and think, okay, these are aggressive. I can slow down on decision making with these. This is what I need to do with these. Can you help us with that?
Yeah, absolutely. But I'm not going to do it justice the same way that my book, The Smart Woman's Guide to Breast Cancer, will do.
Okay.
And I honestly think that this is not self-serving. This is a book that every single breast owner needs to read.
Absolutely.
Right? And
because tied to this conversation, not to interrupt you, but tied to this conversation, sure, we can talk about breast cancer, which we're about to do, but there's also breast health, and we need to understand that as well. And we don't dive into breast health. Now we might think about things metabolically or physiologically, but we're not talking about the breast. So I feel like those are the two buckets that we really need to get into to help our viewers and listeners.
Yeah, absolutely. So I'm going to start off by saying that the way that I approach who gets treatment and what treatment they get or don't is, do you have clinical disease? So do you notice a change? Does the finding in your breast have a presence? Do you feel a lump? Has the appearance of your breast changed? Do you have nipple discharge? Do you have any pain or discomfort? Because I am going to always defer to the signals your body is sending you. So someone with a finding on an imaging study that comes to me and they have absolutely positively no symptoms, and I, being, highly, highly trained to examine the breast and also to really dive deep for symptoms, if I can't find any, I am not intervening. Their body has that. Like, they're good.
So no symptoms, no signs.
I'm not treating subclinical disease. I don't really believe in it, especially because what we have, the way that we treat breast cancer does not bode well in the long run for women, because most of the treatments that we have for breast cancer, surgery, maybe there's some deformity associated with the breast. Can people live with that? Yeah, people can live with that. But all the anti-hormonal treatment, the chemotherapy, the radiation, this accelerates heart disease, which is by far and away exponentially the number one threat to a woman's life. And so if we are treating something that would have never affected them in their lifetime, right? Like they have subclinical changes in their breast, and we now give them a diagnosis and treat them for breast cancer and give them heart disease or accelerate their heart disease, have we helped them? Did we help them? Right. Not at all. So I always start off with, where are you right now, right? Do you have any evidence of clinical disease? If you have evidence of clinical disease, I'm treating that. I don't know that I'm throwing everything at it, right? I am taking you, meeting you where you are. And if it's DCIS or ductal carcinoma in situ, well, that we know, like, we have plenty of time to deal with that. If you did nothing about that for a year, 2 years, 5 years, it may never progress to be anything. I'm not suggesting that people do nothing.
Right.
right? Like everyone who comes into my ecosystem, you're doing something. You just may not be doing what the conventional cancer world is telling you to do.
Right.
And, you know, I don't come by this lightly. I spent 20 years as a surgeon treating breast cancer, running a cancer program, right? An NIH accredited cancer program. I didn't just fall off the turnip truck. Or I'm not some like woo-woo doctor out there saying like, oh, let's treat cancer with black salve.
Right.
Like, no. Right. But there are some people with subclinical disease who I don't think need to go through the rigors of what we consider the right thing to do in everyone, all comers with breast changes. Right. So a lot of DCIS I am watching. The flip side of it is if you come to me with DCIS and you have a mass in your breast that you can feel, or you have nipple discharge, or you have some symptom, that's invasive cancer until proven otherwise, from my perspective.
Got it.
Like if you have some kind of physical change that I can recognize, in my opinion, there's more there than you think, right? And so I'm far more apt to treat that.
And what is that treat? Is it, again, the same drugs and the same chemo?
It depends.
Yeah, okay.
It depends. And so with invasive cancers, I'm also probably going to spend a few months trying to figure out what's going on with this person before I commit them to treatment if they are totally asymptomatic. If they have a symptom, then I believe in treating breast cancer that has clinical symptoms, that there is clinical disease. I just don't believe in treating all of these asymptomatic, like microscopic cancers that are simply being diagnosed because we decided to screen. I don't think we're doing the right thing by those people. And when we look at the data, I know that we're not doing the right thing by those people. So that's so
different from what people are hearing.
Yes.
And the decision making.
Yes, because unfortunately, we're very useful idiots.
Yeah.
We are.
So, okay, then what about a patient recently, if it's ER PR positive?
Yeah.
How does that change things? What does HER2 negative mean or HER2 positive mean?
So when we look at the tumor cell, there are some characteristics that we look for, and we mostly look for them for the purposes of what can we use in this instance. And some of the information is useful, and some of the information is just simply misunderstood. So you're a hormone expert. Let me ask you, what effect does progesterone have on the breast?
It's anti-inflammatory.
Yes. And it's also anti-proliferative.
Right.
So when we look for these receptors on the cancer cells, we look for estrogen receptors. We look for progesterone receptors because we can, not because we understand what they mean or what they do. And we look for a protein on the cell called HER2/neu. And if we see these receptors on the cell, or these proteins on the cell, we say they're estrogen positive or progesterone positive or HER2 positive. And then we kind of hand that sheet off of paper off to the medical oncologist who designs their treatment around this receptor positivity. Now, the first thing you have to understand is all of these things are normal. It is normal to have estrogen receptors on the cell. It's how the cell knows to grow. It is normal to have progesterone receptors on the cell. It's how the cell knows to stop growing. It is normal to have HER2/neu protein on the cell. It has to do with cellular regeneration. And these estrogen, progesterone, even HER2 proteins are found in cells all over the body, not just the breast. They're not nearly exclusive to the breast. They're literally all over the body, which is why when we use medicines to target the HER2 protein, we have to be careful and do things like monitor the heart.
Right.
Because guess what the heart cells are very rich in? They're very rich in HER2 new protein.
See, we don't hear about this.
So if you use Herceptin to treat a HER2 positive cancer, you could at the same time do some significant damage to the cardiac cells.
Wow.
To the heart cells.
We're all connected, guys. We talk about this all the time.
Yes.
It's all connected.
Yes.
Yep.
So this is why we have to so thoughtfully and gingerly approach this, but you only hear the narrative that the pharmaceutical company wants you to hear. And I think it's so interesting that, like, why don't we test for androgen receptors?
I have said that for
on
years,
breast cells.
and I'm not even like a breast cancer specialist.
Yes. Do you know the answer why?
No, I don't.
So if we look at the research out of Rebecca Glazer's practice in Ohio, she just released her 2025 20-year study, and women treated with testosterone, with or without an aromatase inhibitor, because in our body, physiologically, testosterone will convert to estrogen.
Right.
So with or without an aromatase inhibitor to prevent some of that conversion to estrogen, they have a 47% decreased incidence of breast cancer as compared to the general population that are
treated
not
with testosterone. Okay, you're gonna have to explain that.
Yeah. So when we were trained to do menopausal hormone replacement, what were we trained on?
Estrogen and progesterone. Estradiol and progestin usually.
Well, not even estradiol. We were really trained on conjugated equine estrogen, and progestogens, right?
Yeah.
We were trained on to give people Prempro.
Right.
So we were never trained on giving women testosterone. It was heresy to give women testosterone. Well, for whatever the reason, Rebecca Glazer figured out a long time ago, early on in her career, and she's a breast surgeon by training, that if you give testosterone to women with proliferative breasts, with proliferative lesions, and in the context of your menopausal hormone therapy, their lesions either regressed or they didn't go on to develop breast cancer. And so she kept doing it and kept studying it and kept doing it and kept studying it. And she just released her 20-year results.
Wow.
And her patients, who she routinely treats with testosterone, she actually doesn't even give estrogen. She just gives testosterone. They have a 47% decrease in the incidence of breast cancer as compared to the general population. So she's comparing her results.
Right.
So granted, it is a single physician study, right? She's comparing her results to the SEER results, our national data bank, but she shows a huge decrease in the incidence of breast cancer in her patient population. Now, in her practice, not only is she using it for breast cancer prevention, but she's also using it for breast cancer treatment in the metastatic population and getting tremendous results. So let's back up to the question of why are we not looking for androgen receptors? Because if we look for androgen receptors and we find them, and testosterone can be used to treat and reverse breast cancer, how does that benefit the pharmaceutical industry? because they can't use bioidentical testosterone because you cannot trademark a molecule of nature. Yeah. So who's doing that study?
Back to the usual problem we have. So, but what about, okay, so I'm curious, this is more selfish. I'm curious, as someone who's very androgen sensitive, right? Like slight increases in testosterone or free testosterone or DHEA, acne, hair loss, weight gain, all the things.
Yeah.
We have an androgen epidemic a little bit with the higher cortisol levels that most women today are experiencing. There's a relationship between cortisol and androgen excess.
Yeah.
So would those women benefit from testosterone, or have we studied those women?
They would, but first of all, you need to know their genetics. You need to see how you need to support them. You know, maybe you're giving testosterone along with a little bit of an aromatase inhibitor to prevent too much conversion to estrogen. You need to see where you need to support their estrogen detoxification pathways. And like maybe they also need a 5-alpha reductase inhibitor so that you're not converting that testosterone that you're giving them to 5-alpha,
right?
To the 5-alpha variant.
Absolutely.
So it can be done, but it has to be done thoughtfully with awareness of the person sitting in front of you and what effect it has on them. And I also think that we need to school people on genetics and the detoxification pathways. And they also need to be able to look at the results, look at the metabolites, see where people are getting in trouble and help them. And we can, if you know the pathways and you know how to influence the pathways, you can support them.
There's so much we can do from a proactive, preventive standpoint, and I'm watching my time, so hopefully we can get there. But, you know, I do want to touch upon the women that have been diagnosed with ER PR positive breast cancer and have gone on anti-hormone therapy, and then have had much of the fallout of anti-hormone therapy, whether it's depression or weight gain or joint issues or all kinds of metabolic disorders, right?
Awful. I call her the forgotten woman.
They ask me if, as a hormone expert, as you mentioned, should they be off their anti-hormone therapy? And is it okay for them to do very low dose bioidentical hormone replacement therapy with like a bioidentical, estrogen or bioidentical progesterone?
Yeah.
What would you say to those women?
Yeah. So let's look at the data.
Yeah.
Because we have lots of data from the SOFT trial about suppression of ovarian function. And what we know, and I think Jeffrey Dash writes about this brilliantly in his book, Bioidentical Hormones. Get the one with the puzzle face. When you deprive the cells of estrogen for a long enough period of time, what happens when you start to reintroduce estrogen is that it becomes very toxic to the cancer cells. It's like refeeding. You know that phenomenon of refeeding when you've had starvation for a long time, and then if you refeed too quickly, it's very toxic. It's the same thing for the cancer cells. So we know that when we have women who have been on estrogen deprivation for the purposes of treating the cancer, about 4 years is the sweet spot. And then you start to reintroduce estrogen again and in the form of estriol, estradiol. I usually recommend Biest.
Right. My favorite.
And those women actually have a far better survival and a decreased risk of recurrence.
4 years post. Interesting. Well, that's kind of a message of hope right there.
Yeah. Amazing. So for women who have been like 5 years on estrogen deprivation therapy, 7 years, 10 years, and they come to me and they want hormone replacement, it's a hell yes for me.
Amazing.
Because I know that you're going to benefit their heart, benefit their brain, benefit their bones, benefit their joints, benefit their bladder, and you are not going to increase their risk of recurrence, and you're going to make them happier.
So, but in this estrogen replacement or hormone replacement, does it need to be bioidentical?
Yes.
Versus the traditional
Yes.
estradiol patch and
Yes.
progesterone
I mean, the
pills?
estradiol patch is bioidentical. It's just not
Right.
the way that we would do it.
Right.
But the studies weren't on bioidentical, biased.
Mhm.
The studies were on they were on bioidentical progesterone. But some of the studies were on the progestins. It's just that those are the studies that didn't have the good outcomes.
Let's do one more. Triple negative breast cancer.
Yeah. So the thing about triple negative breast cancer and what that means is that you don't have estrogen receptors, you don't have progesterone receptors, you don't have HER2 new protein on these cells. The reason why these are considered the bad actors, what the industry will tell you is that we have less treatment that against them that can affect them. We can't manipulate the HER2 protein because it's not there. We can't manipulate the estrogen receptor because it's not there. The real problem with that is that when you look at that cell is a very, very far departure from the normal breast cell. It is really mutated. That cell is lost, far gone. It's very difficult to recreate the environment where those cells would become normal again, where those cells would become safe again. So for me, the real challenge with that patient isn't, oh, I can't use tamoxifen or aromatase inhibitors or Herceptin or Perjeta or any of the other treatments that are routinely used for HER2 positive or ER PR positive, that kind of thing. And I want to get back to PR positive. But the real challenge is, why is this person so shifted? Because cancer is a normal response to an abnormal environment. What is so environmentally shifted about this person? Where is their toxic burden? Can we find it? Can we reverse their toxic burden so that their cells don't have to feel so threatened? So that they don't have to be so uber and overly responsive to whatever this is happening here. That's
where you
the
like
thing
to focus
with this patient. Will they respond to chemotherapy? Yeah, most of them do. But the problem is when you give these women chemotherapy and their body is already screaming that I'm toxic, right? That's where the cancer came from in the first place. And you give these women chemotherapy, you essentially take their immune system out of the picture because it destroys the immune system, destroys the immune system.
Drives more inflammation.
Yes. So you have some seeming short-term gain because it will get rid of the cancer temporarily in many women.
Yeah.
But the long-term price that they pay is enormous. And unless you can figure out where their toxicity is coming from, reverse it, kind of reset their system, you're not going to get durable long-term results. And in fact, the long-term, it looks pretty bleak in these women. So it's not that they don't have aggressive disease. They do. But our aggressive approach to that woman who is already suffering, who is already screaming that this world is not working for them in the way that they have it right now, we're not serving them. But we're making ourselves feel better by giving them a drug and saying, hey, look at this response that you got. Big pat to me on the back. But then they're back in your office a year later with widespread metastatic disease.
Then? Like, I can see somebody listening who's like, well, what am I supposed to do? Like, I've been diagnosed with triple negative cancer. You know, I've been diagnosed with ER PR positive cancer. You know, my doctors are saying mastectomy, you know, chemo, radiation.
Yeah.
What is it that we should do? Here's what I've heard from you already is first decide if it's clinical or subclinical. That seems to be step one.
Yeah.
But then what's step two? What's step three?
Yeah. So we need to do like a whole body workup. The first thing everyone should do is take a breath. take a pause. Know that you have time. Yes, that. Do that like 100 times and know that you have time and space. With rare exception, there are some exceptions. You mentioned inflammatory breast cancer before. Right. That's an emergency. You don't have much time.
Yeah.
You need to figure out what's happening and deal with it. If you have a metastasis to your bone that has caused a fracture, these are very painful.
Right.
It is nearly impossible to heal while you are suffering in pain. That needs immediate treatment. If you have mets to the brain, right? The skull is a fixed space, and metastatic disease or tumor deposits in your brain, they cause a lot of swelling, edema. You're not going to be able to tolerate a lot of that. That needs immediate treatment. And everything else, you really have time. So figuring out what's happening with you before committing to treatment is pretty important. And you have a month to do that. You have 2 months to do that. Mm-hmm. So everyone should start by reading my book, The Smart Woman's Guide to Breast Cancer. And literally, it'll take you 2 days. I wrote this in a way that you can get what you need from that book right away.
To start a plan and to guide you to a certain extent.
And it's every question that you need to be asking the surgeon, that you need to be asking the medical oncologist, the radiation oncologist, so that you go in there prepared. So everyone who gets a breast cancer diagnosis gets a treatment plan. They're a dime a dozen. Most of them are exactly the same. Like, people talk about going to get a second opinion all the time. If you get an opinion from a surgeon and you get another opinion from a surgeon, you're not getting a second opinion. They're all saying their version of the same exact thing. But a second opinion from someone like me, who's integrative, who knows and understands the whole conventional side, but then says, what are you eating? What are you drinking? What are you thinking? Yeah. What have your traumas been? How much stress are you under? What is your toxic burden? What are your detoxification practices? How are you moving your body? How often are you moving your body? And we are looking at your genetics. We not like, do you have a BRCA mutation or one of those things, but we're actually looking at your functional, actionable genetics and saying, how can we create an environment for you that fosters health rather than creating disease? Because you cannot get better in the same environment that you got sick.
So it comes back to whole body health.
It does.
How everything is interconnected.
Mm-hmm. And it's whole plus.
I didn't think we needed a part 3, but now it's looking like we need a part 3. but before I let you go for today, I do want to wrap this up into a prevention conversation around breast health.
Yeah.
I know you have different ideas around screening. If you were to, could wave a magic wand and told every woman to protect their breast, here's what they need to be looking for, here's how to screen, what would you tell them?
Yeah, so this is such an easy answer. First of all, I think everyone should be doing self-breast examination. Not that it's going to find something in its infancy, but the way that I think it's important to know your body and know what your body feels like, and no one's ever going to know you better than you know yourself. So everyone should be doing self-breast examination. But the answer to how everyone should be screening is already here, and it's in the United States, at least, universally available. So it's something called the ARIA Tears test. I don't know if you've heard of this test.
Well, you educated me on that.
So this is an at-home screening kit, and it uses your tears. So there's a tiny little litmus paper that you put inside of your eye. I should have brought you kits. Tiny little litmus paper that you put inside of your eye, close your eye for 5 minutes, send it off to the company. It doesn't hurt. You don't have to poke yourself in the eye, make yourself cry, nothing like that. A week and a half later, you get your report, and you either have a negative result, in which case this test has a 93% sensitivity for breast cancer. If you don't feel anything in your breast and this test is negative, you don't have breast cancer. If it is clinically positive, then you need imaging, right? Mm-hmm. So now the specificity of this test is around 58%, meaning that 42% of the time, if you don't have breast cancer, this test is going to be positive. Now, people are outraged by that. They're like, oh, there's so many false positives to this test. There are no false positives to this test. This test does not measure for breast cancer. This measures for the inflammatory precursors of breast cancer.
Do you have inflammation?
If you have the inflammation, and this inflammation happens to be specific to breast cancer, if you have this specific inflammation, elevations in the monomers, the S100A9, A8, and S100A9 proteins, when you put them together, the dimer is called calprotectin. I'm sure you've heard of that.
Oh, yeah.
But separately, these proteins, when they are both elevated to critical levels, are highly predictive of the very early stages of breast cancer. So if you have a clinically positive result and you do nothing, in 6 months, 11% will have clinical evidence of breast cancer. That's how predictive this is.
Wow.
So I tell everyone who gets a clinically significant result, you need imaging, absolutely. And if there's something there, you need to act on it. But if you have nothing on imaging, guess what you have? You have the opportunity to prevent breast cancer. And the way that we do that is we look at your diet. What are you eating? 80% of our exposure to the outside world, 80% of what will affect our health is through what we eat and what we drink. So what are you eating and what are you drinking? Right? Diet, drinking, alcohol avoidance, decrease the number of toxins that you come into contact with every single day. The average woman before like 9 o'clock in the morning has already exposed herself to like 151 toxins or something crazy like that. We need to be far more conscientious about what we put in, on, and around us. But in addition, we need to have detoxification practices.
Yes.
We need to be peeing and pooping and moving our bodies and sweating and breathing. I mean, this is how we get rid of our toxins, and we need to have these practices. We must have these practices.
I'm going to ask you this question because there's so much, in the wellness world right now of doing this and doing that. Is there one modality beyond diet, exercise, sleep, managing your stress, of course, moving your body, all these different things? Is there one modality out there that you've seen that's a great way to detox quickly?
Yeah, I can't say enough about sweating.
Sweating. So sauna?
Yeah.
I love my sauna.
Yeah. And I think that it accomplishes so much because when you're in that sauna, yes, you do get that physical benefit of sweating and just getting the toxins out that way. But if you use that time wisely, you're also doing your deep breathing. Mm-hmm. So you're getting toxins out that way. You're also doing your meditation. So you're getting those toxins, those toxic thoughts that have such a profound effect on your life, your health, how you perceive the world, your stress. So I think that 20 minutes or whatever, and you can keep it to 20 minutes because if you go into your sauna hot, you don't need that much time in there to warm up. Yeah. So I always tell people either go in right after you exercise, go in after you drink hot tea, something, go in hot and spend 20 minutes in there doing your deep breathing, doing your meditation, and you have just really set the stage for a detoxification. Shower afterwards, put a shower filter on your shower head so that water is filtered and you're rinsing off toxins and not bringing in more. Yep. And then drink your filtered water afterwards. This will go a very long way towards cleaning out your body.
Wow. That's so helpful and so encouraging. And you mentioned imaging.
Yeah.
Tell us your favorite way to image.
So when we're talking about screening, and right now I am only talking about the screening population,
right. Screening
okay?
and prevention.
Screening, we are talking about healthy women
Mm-hmm.
who we have no reason to believe that they have breast cancer.
Right.
Right? In this population, I think it is unethical to expose them to anything that could harm them.
Right.
So that's why I don't use screening mammograms, because it is radiation. It's an x-ray. We gave it a nice, pretty name. We gave it mammogram, picture of the breast, but it's still a pig. No matter how much lipstick you put on that pig, it's still a pig. It's an x-ray. And in every other situation, x-rays cause cancer. It applies to mammograms too. So don't be fooled. So I don't use mammogram and I don't use MRI for screening because of the gadolinium. And the non-contrast MRIs aren't worth anything.
They aren't worth it. That's really important for everyone to remember.
Yes.
Yeah.
So I recommend QT, which is sound wave technology transmitted through a warm water bath. So it's like a spa day for your breast. But it collects 200,000 times more data points than MRI and creates a true 3D reconstruction of your breast without pain, without compression, without radiation, without gadolinium, right? So 100% safe for everyone. There are only a few centers across the U.S. I mean, my Perfection Imaging, which is in the suburbs of Philadelphia, was the first independent screening center that uses this technology. That's the bad news. The good news is I'm putting up 50. So
Amazing.
Be patient.
Yeah.
Be patient. This year, this next coming year, 2026, you will see a lot of Perfection Imagings coming to a town near you. So be patient.
So excited.
Yeah.
But in the interim, I already told you I'm coming to you.
Yes.
So
yes. And I would love to have you.
Scans.
I would love to have you. And we're putting a second scanner into my
Facility.
Philadelphia location, just
Awesome.
because there's a huge, as you might imagine,
Yes.
a huge demand for this.
Right.
If you don't have access, go get an ultrasound.
Okay.
Now, a lot of people, that's very difficult for them because most of the women's imaging centers will not give you an ultrasound unless you agree to a mammogram.
Right.
So, there is something called a HER scan. They have vans and
it's a mobile scan.
Yeah. And it's better than nothing. Is it great? No, it's not great, but it's better than nothing.
Okay.
Now,
which is an important point, by the way, guys. We are not saying to do nothing.
No.
This is not about doing nothing.
We are not.
Right? A lot of comments were like, this, I did this, I did that. What are we supposed to do? You have to do something.
Yes.
Do something.
So, the something is the ARIA test.
Correct.
Like everyone needs to be doing the ARIA test. Now, I want to be very clear. I am talking about the asymptomatic population here when I say the only imaging you should be doing is QT or ultrasound. If you have a lump in your breast, if you have nipple discharge, if your breast looks different, if your breast is big and red and swollen, if you have new pain, if you have any new symptom in your breast that you can't explain, like obviously if you got bumped in the breast and you have a huge bruise there, you can explain that.
Right.
I'm not worried about that. If you have a new symptom, you are not in the screening population. You are in the diagnostic population. You need to do what you need to do to figure out what is going on there. You need to see a breast specialist. Most of the time, they are breast surgeons. And the breast surgeons only speak the mammogram, ultrasound, MR language. You're going to have to speak their language. You're going to have to get those studies. Can you prepare your body for those studies? Yes. I tell people I have a pre-mammogram or CAT scan or whatever radiation emitting study that you're going to have. I have people taking high doses of melatonin and vitamin C and glutathione to prepare your body with lots of antioxidants that can kind of soak up those free radicals that are created at the time of radiation and hopefully protect yourself against the damage of radiation. I also have an MRI protection protocol to try to prevent your body from absorbing that gadolinium and facilitate your kidneys
Is this all in your book?
of excreting it. It's in my book. It's on my website. I'm trying to help people. I really am trying my hardest. And, for all of those people that, what am I to do?
Right.
These are my only choices. They're not your only choices. They're the choices that you've been told to do. And they are depending on you being a good little girl and just follow along. And this comes back to where we started. It's all about virtue signaling. And am I being a good little girl? So do you want to be a good little girl? Because good little girls who get their mammograms every year have a higher chance of breast cancer, have a higher chance of being diagnosed with breast cancer. And every mammogram you get increases your risk of getting breast cancer. It's the perfect way to become a patient.
I think we're all tired of being good little girls.
I know.
It's a very tired paradigm that everyone needs to throw off officially.
Yes. Well, I
Oh my
wore the
gosh.
perfect outfit to not be a good little girl
you definitely
today.
don't look like a good little girl today.
I dressed like a badass
Oh my
today.
God. I mean, we could continue to go into the weeds here, but I hope the message that everybody has received is at least to take a breath, slow down.
Yes.
Understand your body, understand that there's more at play here than just purely just your breast. And I think that's why I'm so passionate about what I do and really wanting everyone to understand, it is whole plus. It is putting all of it together.
Yes.
No matter whether we're talking about the breast or you're talking about the brain or you're talking about something else, you have to put everything together.
Yes.
So thank you so much
You're
for
so
coming
welcome.
back. And I'm going to ask you the same question again because I can.
Ooh.
What makes you whole? And let's see if you have the same answer or if it's changed from season 1.
Yeah. So it always comes back to God and my family.
Yeah. I don't think it changed. I think you said that last time too.
Yeah.
Those are the pillars,
Yeah.
right?
I mean, at the end of the day, you're on a big mission. I'm on a big mission. And we were all put on earth by God for our unique mission. And nothing lights me up. Nothing fills my cup more than when I know that I am living my mission, serving my purpose. And that is to be a light onto this world and to love my family and prepare them for their mission. I mean, that's really what it's
Got
about.
Chills. So powerful. And that mission shines through. It's so obvious. And so thank you so much for all the work you're doing, for all the women all over the world. We are so appreciative because I know so many people just feel backed into a corner. They think they're checking off the boxes and then they don't understand why things sometimes turn into a different direction. So thank you so much. I appreciate it.
My pleasure. Thank you so much for having me.
Oh my gosh.
Can't wait
for
for part
everybody
3
else
to come up with another
part
outfit.
3. We need a part 3. So for everyone else watching and listening to this episode of Whole Plus, we do post new episodes every week and we're only diving deeper, as you can see from this conversation right here. I'll see you guys next time. Before you go, remember, healing doesn't happen all at once. It happens in moments. If today's episode gave you one of those moments, subscribe and keep learning with me. The next video is right here and it picks up right where this one left off.